Welcome, everyone. My name is Lisa Bailey, Specialist Communications for Health Promotion at the Caribbean Office of the Pan American Health Organization. I am so excited and humbled to have been asked to moderate this critical conversation. I am a passionate communicator who has worked in every area of communications in my over 20-year career. Then I fell in love with public health. I now work with PAHO to improve the health of the people in the Americas. And so this topic of universal health coverage is near and dear to my heart. Now, according to our sister organization, the World Health Organization, universal health coverage, or UHC, means that everyone has access to the full range of quality health services when they need it, and where they need it, without financial hardships. Now, it covers the full continuum of essential health services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. Now, progress towards UHC has suffered a serious setback as a result of the global health crisis triggered by the COVID-19 pandemic. Consultations conducted over the last 2 years by the Civil Society Engagement Mechanism for UHC 2030, a multi-stakeholder platform working to accelerate universal health coverage worldwide, identified a number of important and recurring issues that all countries need to strive for. Now, here are a few of the comments received from respondents from Commonwealth countries. So as you can see, we talked about leaving no one behind. A quote from Malawi says, "Rich people are more favored than poor people when it comes to having good access to health services in Malawi." As it relates to quality of care, we see a comment, despite district nurses indicating a roundup program for people with mental health conditions, these people then encounter health personnel who do not want to deal with them or who do not know how best to interact with them. And this came from Dominica, right here in the Caribbean. In terms of moving together, there's a comment about reports from CSOs, but hardly ever accounting back to them. So that feedback mechanism, we involve the CSOs, but actually reporting back to them on what has happened in terms of the information provided to a ministry or any activities. And this came from Eswatini, a CSO in Eswatini, sorry. In terms of investing more and investing better, there's a recommendation from Malawi that government spend at least 5% of its GDP or at least 15% of its annual budget on health. But then there's a lack of political will, misuse of funds, and other issues. In terms of gender equality, which we will talk a lot more about today, women and girls, according to a participant in Sri Lanka, she says are much more challenged in accessing health services before going to health services by family, challenged by doctors when they're at the clinic, or just because that they're women. So there are a lot of issues that came out of those conversations and respondents from you in the Commonwealth. Now, gender inequality has been widely acknowledged as a major impediment to accessing healthcare and support. While action is required across many fronts, the lessons of the past several years confirm that attention to gender dimensions is absolutely critical, and it requires serious and sustained efforts. So this roundtable brings together a formidable panel working at various levels in the health sector, at the global, regional, national, and local levels. And you are also experts in health and/or gender equality in your own right. So we're looking forward to hearing from you too in the second half of the event. So we want to thank you for signing up to be a part of this process. We were well oversubscribed above the 75 spaces that we put aside for this conversation. So what we want to do, because you are a part of this conversation, is to please, we ask you to add your name and your organization to your Zoom ID so we have a good idea of who's in the room. So let's meet our first 4 speakers. I invite you all now to turn on your cameras as we start our first conversation. Hello to everyone. Let me introduce our first panel. We have Dr. Ebere Okarike. She is a public health physician specializing in public health policy. She is currently a senior technical advisor at the Tony Blair Institute for Global Change and is an honorary senior public health advisor to the director of Africa Center for Disease Control and Prevention. Welcome, Dr. Okarike.
Thank you for having me.
Good morning, good afternoon, good evening, because we have people from across the world today. Donna Da Costa Martinez. She is Deputy Regional Director for the Americas and the Caribbean at International Planned Parenthood Federation and a representative of the Civil Society Engagement Mechanism for UHC 2030. She serves as co-chair of the Caribbean Vulnerable Communities Coalition. Welcome, Donna. We have Dr. Harjot Kosa, Senior Technical Advisor at the International Planned Parenthood Federation for the South Asia Regional Office. She is also a member of the advisory group at the Civil Society Engagement Mechanism for UHC 2030, and her focus is on gender-based violence and sexual and reproductive health, as well as LGBTQ rights. Welcome, Dr. Harjot Kosa.
Thank you, Lisa.
And finally, Dr. Rispa Wulumbe, a global health specialist, currently health policy advisor at African Medical and Research Foundation, AMREF Health Africa. She specializes in advocacy and healthcare policy, focusing on the advancement of universal health coverage at a national, regional, and global level. In section 2 of this event, we'll talk to speakers who work directly at the community and local levels. But right now, let's talk with our first 4 ladies here. I'm going to start with you, Dr. Ibire. What would you say is the state of play in the Commonwealth countries right now in universal health coverage implementation? What targets are being met and which ones are we not meeting?
Thank you for having me in this really important conversation. And it's really an honor to discuss this really important thing. I would wish to start with on a positive note, but regretfully, I think that's quite difficult because we're not meeting any targets. We're not doing very well at all. If anything, recent events and the focus on the pandemic has taken us backwards in all the key indicators for equitable access to health services, from prevention all the way to palliative care. That's what UHC is supposed to be. But what we've actually seen is a regression in access across the board in most of our Commonwealth member states. Focusing on African Commonwealth countries, which I know more about, the fundamental challenge remains accessibility, even of what is there, irrespective of the issues around the quality of those services. The services are not enough for the needs of the populations. The quality is questionable. Too often, services are difficult to reach for the people most in need. Efforts across the Commonwealth to address universal health coverage have primarily focused on health insurance programs. And most of those had focused on people who work in the public sector. Obvious reasons why you would start there. Those are the data sets and the people you can reach first. But that means that the most marginalized are even more marginalized than they were because they're less able to access those systems that are available. Also, one of the concerns that we've noticed in recent and the pattern where we've focused on health insurance-based focus is the move even further to provision of services in the private sector, where there is even more challenge in quality assurance and managing the costs. So in effect, our attempts to actually improve universal health coverage are at risk of actually making it more difficult for the most marginalized and most in need sectors of our population. And fundamental to all this, of course, is a recognition of the issue of some subgroups are even more disproportionately affected by this approach than others. Women who bear the brunt of our healthcare in terms of unpaid care delivery, in terms of taking responsibility for health provision. They are the workforces, and the lower down the health delivery systems you go, the more there are women responsible for that. They're not part of the conversation. They're not included in the discussion, and they're not included in the solutions that are being created. And then one of the things I'd like to close on that, because I'd like to give my colleagues an opportunity to say some more too, is the primary issue here remains an underinvestment by governments in the health sector. In recent years, the focus has been on global health security. That is my area of specialism. So I have seen the focus of attention, both domestic financing and donor international support mechanisms, focusing on those aspects of the health system that contribute to health security. And what we have seen as a consequence of the pandemic is that you can't have health security if you don't have a resilient health system that is accessible by everyone, including the most marginalized. Without that, you don't have trust in the system and you don't have utilization of the system in an emergency. So we have got to pause and think that the primary step towards pandemic preparedness, health security, is to first and foremost go back to that primary question of a universal health coverage that is accessible for all.
Thank you so much, Dr. Ibere. I'm going to give everyone a chance to come in on this one. I appreciate that you wanted to start with a positive, but I understand what you're saying. There are not a lot of good things to say in terms of where we are with universal health coverage. Ms. Martinez, let's go to you in terms of the Americas and the Caribbean. Do you agree? You're muted.
Yeah, I totally agree with Dr. Ibere. I think that for us in the Americas and more so in the Caribbean, I'm very, very concerned about issues around the girl child and women, of course. I think that we have lost some speed in terms of looking at the sexual and reproductive health and rights of young people in particular in our region. The issues related to them having the necessary information, having the necessary services and so on, that they can access sexual and reproductive health and rights in a way that is pleasant, in a way that people understand what their needs are, and also giving them the opportunity to express what they think that they need for themselves. And I really would like to see that we are able to put more focus in this particular area. And I think it really speaks to the policies and the laws that we have in place that really does not facilitate, particularly in a time where we are expecting that everyone should have universal access to health. The issues around young people, particularly, and having access, for instance, to simple, comprehensive sexuality education, that they can be informed, that they can make decisions about their health, that they can avoid some of the pitfalls in terms of unplanned pregnancies, issues around topics like the abortion, and being able, even in the case of rape and incest in some of our countries, to be able to have access to these kinds of services. And also recognizing in terms of our policies need to be updated. Our policies really have to reflect what the statistics are saying to us in terms of our young people and their needs. And I speak particularly about our ability to be able to draw on the Gillick competency module, for instance, to give healthcare providers that access, that need to be able to serve without feeling that they could be victimized because of the laws that are in place. I think this is a very big issue for us, and I really feel that some great attention should be placed on these in particular when it comes to our young people.
Thank you so much, Ms. Martinez. I think I'm getting the feeling that we may all agree that we are not meeting those targets. I'm going to come to you, Dr. Harjot, and maybe you can talk about the pandemic and the experience of the pandemic as well. Has it helped to show us, maybe accelerate the need for changes to make UHC a reality? Dr. Kosa.
Yes, so thank you so much, Lisa, and thank you, Donna. And because what I was thinking, you have started talking about it. And, Lisa, thank you so much for the reflections which you shared in the beginning, especially from Malawi, where, there was a feedback that the pandemic has shown us the disparities between the rich and poor. But I think it's not just rich and poor, it's the gender. Men, women, trans people, communities, LGBTQ populations. We as governments, as policymakers, as implementers, we have to wear the gender transformative lenses. This is not black and white, it's a spectrum. We have to think from that angle. Secondly, and thank you for raising the points for marginalized communities. It's good that now people are talking about it. We are talking that vaccinations are reaching and, just 20, 30% people in the countries are left. But who are these 20, 30% people? These are the people who are undocumented migrants, or maybe, these are the marginalized communities, trans people. So we are just leaving the most marginalized in the pandemic at the most peripheral of the system. Then also, we had beautiful mechanisms also. I also want to highlight like, ACT Accelerator. It came up as a global partnership, and now we are on the verge of moving and planning for the next phase. How do we respond to future pandemics? We have a model where governance, donors, communities, CSOs, partners, all of us came together. That's global solidarity. I think one thing that we learned from it is that if that is there, we can respond to any pandemic. Secondly, I also really like the feedback from Estavani CSO. They were talking about data, and people who know me, I have been talking about that data is there, but this data, one number is an individual. What is the story behind it? What is the narrative? Why is this data here and not here in red highlights or green highlights? That's another thing. And lastly, you shared about Sri Lanka. Sri Lanka is one country among many countries who are just coming out of crisis. How are we planning to make strategies which are very focused at regional and at country level? It's not just women in countries in the global south. We have to think strategically for women and health and human rights of women from Sri Lanka, Iran, Afghanistan, all women in the fragile settings. How are we planning to deal with it? I think that's the point. Yeah, thank you.
Thank you so much, Dr. Kosa. I'm going to bring in Dr. Wulumbe here. Do you agree with your colleagues so far? And what do you think about the experience of the pandemic, using that to accelerate what we need to see for universal health coverage?
Thank you so much, Lisa. I hope you can hear me well. So yes, firstly, I do agree with my colleagues in terms of, it's not looking good in terms of what we've seen in the aftermath of the pandemic. But I'm always accused of being a little bit too optimistic. So I think I kind of start to see that as a result of the pandemic, there were a lot of investments on the continent within Africa. Different countries made a lot of investments within the context of strengthening health systems to be able to support delivery of service, which was, I think, a significant, feat to really acknowledge. But I think the one part where we missed out on that was how to sustain those kinds of investments. And that's really critical for us to kind of sit down and think through. I think there's many of us have attended webinars and sessions where we've talked about lessons learned during COVID-19 pandemic. And I'm not sure how well we're picking up those lessons and really applying them in the context of, health system strengthening, resilient health systems, and the larger conversation for universal health coverage. And unfortunately, when you're listening to some of the policy dialogues, a lot of the conversations are still separating global health security and universal health coverage. All of these things we're talking about don't operate in a vacuum. They operate in the context of a country's healthcare system. And you still find right now, when you ever talk about strengthening health systems, everyone shudders when you're talking to policymakers, because yes, it's a big animal. It's very difficult for you to start to talk about, fine, if we say health system strengthening, that's everything. But I would argue a little bit and say that that's actually the place to start, and because that's where those investments are really critical, and that's where you've seen sustained growth in terms of a country's ability to deliver care, and not just care, quality care. Because I think one of the things that we have seen is that countries have increased their ability to deliver on care in the region, if you look at it even from a historical perspective. And they've done this, I would even say, in spite of some of the challenges on the global scale. So, but because people are increasing their health-seeking behavior, you do have instances where things like catastrophic health expenses are on the rise, where almost 100 million Africans were, victim to this. And you have 15 million being pushed into poverty as a result of this. So I think we need to be able to reconcile those two levers in terms of, as we continue to increase access to care, how do we make sure there's a critical balance between being able to pay for these commodities and really making sure that people receive the services that they need at the point of care. And I think Dr. Ibere really pointed out that, a lot of the focus on the region is for insurance mechanisms. And really, that's not the only thing to be able to fund a healthcare system. So it would be interesting to unpack that. Yeah.
Agreed. So let's talk a bit more about, and I feel as though, we survived the pandemic. Those of us who survived the pandemic, which we hope we can soon say is over, we've gone back to doing business as usual. So we survive and lessons learned, but what are we doing different as a result? So how do we do the basics, Dr. Ibere? How do we invest in building adequate and resilient health systems that are efficient, accessible, and equitable for everyone?
I'm going to start by being a little controversial and stating that access to health, which is a human right, is not a business for health ministries, health ministers. It's the business for government. And therefore, it needs to be led from the center of government, because primarily what the determinants of health, and I'm not talking about healthcare access here, the determinants of health sit outside the service provision by the Ministry of Health. So if you task the Ministry of Health as taking responsibility for our health, they are never going to succeed. They don't pull the right levers. So we need to bring this back. And unfortunately, unconsciously or subconsciously, too many of us and our governments bought into those 1980s World Bank view of health as a consumptive process, and therefore one that needed to generate, we needed to control and contain. We need to step back and look at health as a human right. And therefore, your elected government's responsible for giving you access to that right, not the Minister of Health. The head of state should own the responsibility. And we start by looking at those wider determinants: education, access to clean water, those basics. Then we can start to talk about healthcare, the role of the healthcare system in complementing that. But the fundamental thing has still got to be that we need to see health as an investment in our development as a community, a society, as humanity. And we need to look at that as any penny that is put into that is an investment in everything else. If we didn't learn anything else from COVID, we needed to recognize that when there was no health, nothing else happened. So unless we step back and stop thinking of health as a nice to have add-on when we've got a little extra cash, we're not going to make progress. And I don't want the responsibility for health to sit with the Minister of Health. I want that to sit with the President, the Prime Minister, the head of state, because he pulls all parties in to this core commitment.
Now, I think you just repeated my favorite quote from you, where health should not be seen as an expense, but an investment. It is just so critical to this conversation, this very critical conversation. Does anyone else want to comment on that specifically? Dawn, I see you have unmuted. Go ahead.
Yeah, I wanted to say, though, that I really think that the pandemic offers us really huge opportunities to learn lessons for health system preparedness and resilience. And if anything, I think the pandemic has done is that it has made it evident that to improve the health of the population and build healthy societies, there is a need to shift the focus from illness to health and wellness. I think we are too often we are focusing on the illness part of it. And really what we're trying to do is to make everybody understand that it's health and wellness that we're talking about. And we have a responsibility not only for ourselves, but as Ibere says, the government has a responsibility for ensuring that we have the necessary supports and systems in place that will ensure that we have a healthy and a healthy population. I think as well that that in order to address the social, political, and commercial determinants of health, that is even more important that we shift our focus to promote healthy behaviors and lifestyles, and to foster universal health coverage in order to design and implement population health friendly policies, I think we also have to consider that there is a need to improve understanding of the factors that influence health inequalities and the interconnections between the economic, the social, and health impacts. I'm not sure that we are taking those seriously, those issues seriously, and factoring them into the conversation. It's how we should do that. I also feel that there is need for broader policies should be considered not only within the health sector, but also in other sectors, such as the education sector, employment, infrastructure, even agriculture, and those, how are we making the connections? Because those do impact the health and well-being of our citizens. And I think that whatever we propose in terms of policies need to be designed through involving the community, addressing the health of vulnerable groups, and fostering this intersectoral action and partnerships. We're not there yet. We think that, we're not involving the communities. We're not involving those for whom the services are intended. What are their views? How do they see it? What are their real needs? How, they have ideas, and I think it's important that those types of consultations be done with the people on the ground. I think, and the last thing I wanted to say is that the crisis also demonstrated the importance of equipping health systems with both reserve capacity and agility.
Agreed. Really good points. I'm going to come to you, Dr. Kosa, in terms of these practical measures. So we talked about philosophically seeing this as the need for more intersectionality and not seeing health as a siloed issue. Do you think there's some practical measures now that we can drill down to make health systems or social systems more equitable and inclusive?
I will start with my tagline. So no health system strengthening without community system strengthening. We are investing, we really want our systems to be resilient. We need to make our services equitable and accessible. And so, but communities need to understand what's there, we need to build it. So my core, in India, we call it FUNDA, is that community system strengthening has taken us to distances. And also, like in the beginning, we discussed that we all from CSCM perspective, we are here to convene the voices and make sure that the UHC policies are also inclusive and equitable. We are on the verge of having HLM. And, as UHC 2030, we are leading this movement. We have an action agenda in place, which is very inclusive. And we have a multi-stakeholder task force that is working, which is committed beyond that we have to deliver health for all. It has to be there. And there are like-minded people. I think we need to have more solidarity. We are currently working with Shantam House and other on the action agenda, and it will be launched in March. But how do we make sure that these recommendations, which are in the action agenda, which we all are talking here, these are taken up by the countries? We are able to make our health systems more equitable and resilient. And last thing which I want to highlight is that as UHC, we don't want to leave anybody behind. And we want that government should increase the health spending. But we also want that there should be strong health system with RISPA, DONA, my friends are already talking about. But it will not happen till we are going to the primary health system, till we are going to making policies which are reaching to the communities at ground level. Look from the one word is community intelligence. What HIV told us, tuberculosis programs have told us, we need to bring those learnings, as we are moving ahead with UHC and looking at it from the lens of the pandemic preparedness in the future.
Thank you so much, ladies. I wish we could talk for another 20 minutes. We've run out of time for this first section, but I want to thank you so much, Dr. Ibere, Donna, Dr. Harjot, and Dr. Rispa for leading off this conversation. The comments in the chat are very distracting. They're so good. There's so many great comments in the chat already, but you know what? We're going to discuss those a little later in the discussion. So thank you, ladies. Stay around. We're going to move to section 2 of our discussion now, strengthening universal health coverage. What is the state of play? Now we move to hearing from some of our civil society leaders who are working in the Caribbean, an island close to me, St. Kitts and Nevis, one of my favorite places to visit. We're also going to hear from India and Nigeria about why health policies and services need to be gender sensitive and genuinely inclusive. Now, each of the next 3 speakers work directly with women, men, and marginalized communities to improve their access to healthcare. So please turn on your cameras. Abby Beho, she is the founder and director of program management at Lake Health and Wellbeing. Hello, Abby. It's a public health civil society organization in St. Kitts and Nevis, offering public health support to its local, regional, and online communities. We also have Professor Asha Hans. She is Executive Director of Shanta Memorial Rehabilitation Center, a disability rights civil society organization. And she's also the founder, director of the School of Women's Studies at Utkal University, India, and leading campaigner for women's rights, specializing in gender and disability rights. And finally, Rhoda Prevail Theodin is a lawyer and human rights activist. She is the ex officio president of FIDA, International Federation of Women Lawyers in Nigeria, which is a nonprofit association of women called to the practice of law focused on human rights. Welcome, ladies. Thank you for joining us today. I hope everyone's doing well. We're going to start with you, Abby. Can you please tell us why this issue matters to you and what has been your experience working on the ground regarding this access to health needs in communities?
Well, good morning, good afternoon, and good evening to everyone. It's such a pleasure to be here today, really just to answer this question around why it's so important that health policies are gender sensitive. So what I wanted to do is just share some insight from our Commonwealth Foundation funded project to answer this question. So what we did for our project and on the ground was we focused on non-communicable diseases, or NCDs, and we explored the experience of people living with NCDs during the pandemic using a gender lens. And what we found was that men and women have very different experiences when it comes to their health condition. So if we start at the beginning of the NCD journey, so before a person develops an NCD, what we were seeing was that men and women can have different exposures to NCD risk factors. And what we found were 3 interesting examples. So the first was like workplace exposure risk factors. So the jobs that men and women can have can be very different. And what we found in our region is that men are more likely to engage in manual jobs, and thus they're more exposed to things like chemicals and dust. And we know that these are factors that can increase risk of non-communicable diseases. And then what we also found was that women were more likely to have administrative roles, and so therefore likely to be sitting down all day. And we know that physical inactivity is a risk factor for developing non-communicable diseases. The other sort of risk factor issue was around pregnancy. So what we were finding is that women, or some women, were developing the non-communicable disease for the first time during pregnancy. And an example of that was around hypertension, where we had a young lady who expressed that, she first developed her hypertension during pregnancy, and then that persisted years after. And then the final kind of risk factor issue that we identified was that women appear to be more exposed to stress than men because of the many roles that they play in society, and also the challenges of navigating a male-centered society. And that kind of created a lot of stress. Women were overwhelmed, and we found that women were more likely to be exposed to long-term stress. And we know that that also can increase risk of developing an NCD. So those were the issues, or gendered issues, around risk factors for NCDs. But then we also found that the general experience of people living with an NCD can be very different from men and women. So for example, if we look at something like diabetes, women and men can have very different symptoms, concerns, or issues. And an example of that is that women may experience an additional symptoms with diabetes, such as intermittent infections. And whilst for men, their concern might be more around the medication side effects. So understanding that some medications can affect testosterone levels, and that can affect sexual function. And one of the key issues here is that these sort of issues come as a shock to the patient, and that can lead to additional distress. We also were able to identify within the NCD population certain vulnerable groups, and this had a gender component to it. So in summary, some of the vulnerable groups that we identified, firstly, single mothers on a low income living with an NCD, we found were the most vulnerable group. They were trying to manage their illness while balancing a number of roles and responsibilities. And this was sometimes occurring with them having little or no practical, emotional, or financial support. And as a result of this very overwhelming situation, this exposed them again to large amounts of stress, and stress can exacerbate their NCD. So it can make their NCD worse and exacerbate symptoms. The second vulnerable group we found were retired, older single women. Some of these women were at risk of isolation and loneliness, and this was leaving them at risk of not having the support that they needed if an emergency occurred. And what we are finding is that some of these women maybe had people dropping in on them maybe 2-3 times a week, but on the days where they were on their own, that's where they felt a little bit distressed because they weren't sure if something happened with their health, if they would be able to get the support that they needed. The other vulnerable group that we found were women living with chronic reproductive health issues, such as fibroids, endometriosis, polycystic ovary syndrome, and also autoimmune conditions like lupus. What we found in this situation, there was a lack of specialist care, lack of empathy, lack of support, lack of treatment options, and this left women without appropriate medical, practical, and psychosocial support. And then I think it's also interesting to sort of touch on men as well living with NCDs. And overall, what we are finding was that men were more hesitant to seek out help, which I think a lot of us know already. And therefore, they were at risk of not receiving prompt support and medical attention, and thus having a poor outcome. And I think what was interesting in terms of the hesitancy to seek out support was that men tended to have a lack of trust in the healthcare system. And that sort of was the barrier in terms of preventing them from seeking out help. So just to summarize, I think men and women living with NCDs have a variety of different sort of emotional, practical, domestic, professional, and biological needs that have historically been unaddressed and need to be considered when we're developing NCD policies and strategies around universal healthcare. And it's important to get these policies right for people that are living with NCDs, because they are going to be heavy users of the system because they have a chronic condition and they will need long-term regular support and care. So I hope that in a nutshell
Very
answers the
interesting.
question. Yeah.
Abby, that's some really good data for action, I like to call. I feel as though that's some really good insights that I hope we can discuss how maybe you're using it or how that data can be used in your community to make some changes. Let's turn now to Asha. Asha, please tell us a bit about the picture of issues in your region. Professor Hans.
Thank you so much for giving me this platform, and I'm so happy to be here. I work with women with disabilities. So what I will highlight will be the issues of women with disabilities in India as elsewhere. When you talk about universal healthcare, one of the first things we need to remember where women with disabilities are concerned is that they might not be able to get to a hospital. There might not be accessible transportation. The hospital might have steps when they and not have a ramp. They might have an X-ray table which is too high. So, or you have doctors turning you back because you are a woman with a disability and you do not need the healthcare that is should be accessible to all. That is a major issue. But more important than that, and today which I would like to concentrate on, is what is called under Article 12 of the UNCRPD, the United Nations Convention on the Rights of Persons with Disabilities, that you have the legal capacity. It gives you the legal capacity to decide what to do with your body. It decides what you can do, where to live, and how to live. Usually too often we see that young women with disabilities are excluded from family planning and other sexual and reproductive health services. Low levels of sexual education, including education about HIV transmission and prevention, often translate into very risky behavior, sexual behavior. It was found that the kind of work that we did, and in a study that was done, that there is so much of disparity that women with disabilities were 22% less likely to have been screened for breast cancer, and 37% less likely to have been screened for cervical cancer than women without disability. So there is a disparity across the board. But most important is what we deal with is part of universal healthcare, which is not looked at all, is mental health care. Most of the mental health care leaves patients within our incarceration, within hospitals, within mental asylums, within shelters. And this is something that has been increasing during COVID that we have seen. Not only are women not getting enough healthcare, but they are more and more are being incarcerated within institutions. This is something that needs to be looked at. And shelter homes, even in school, they're chained, kept without clothes, raped in institutions that are supposed to protect them. They are not given the right to make their own decisions. There are many, many examples that we can give. Some of these examples are recent examples of women being found chained. As recently as this, but what happens with the law? As recently, it means that you have the legal capacity, means you have the right to decide and to take your own decision. But under the earlier laws, women were asked that they appoint guardians, or guardians were appointed for them. And this still continues. In two cases recently that we saw, one was in Calcutta and one was in Madras, where a woman with a psychiatric help was diagnosed with psychiatric illness. The Calcutta High Court gave a law which was of the 19th century, not the right to have your own equal right to universal health care, but a law which used words like, for instance, it said that you are either you can be not be able to walk, you are crippled, you cannot decide because you don't have you have a mental illness, you are an idiot. So those are the kinds of law that were used. If those laws continued, the judge was wrong, because the rights of persons with disability gives women a disability the right to do whatever they want with their own bodies, to do whatever. That right was not given to them. So as a disability rights advocate, we struggle to seek recognition of universal legal capacity, and to reckon that this needs to end, the prejudices need to end. Thank you.
Thank you so much, Professor Hans. That was distressing to me. I hope we get a chance to talk more about what you're seeing in your area and some of possible solutions. I think it's great that the next person who will speak is a lawyer and human rights activist. Maybe we'll get to talk a bit about what Asha shared, but also please tell us a bit about the communities where you work in Nigeria and your area of work, Rhoda Theoden Moore.
Thank you. Just like you said, I belong to the International Federation of Women Lawyers, and FIDA Nigeria, or FIDA, is an organization of women lawyers called to the practice of law. And our main objective is to protect, preserve, and promote the rights of women and children, realizing that on the well-being of this group of people is the welfare of any nation. And so violence against women is a public health concern, which affects millions and millions of women all over the world. Nigeria is not an exception. In our work in FIDA, we are in all the states of the Federation, because we have branches in all over the country. And in some of the states, we have more than 2-3 branches. So I can tell you that we relate very well with the people in the communities and the local areas. Talking about the rights of women and children, it is key that we realize that health is a fundamental human right, and violence against women is a public health concern, and a human rights issue. So during the pandemic, the COVID-19 pandemic, in fact, we were given the opportunity to be out there despite the lockdown, because we are considered one of those that have our services are key. And I can tell you that we came across so many issues that we couldn't on our own do anything. And it was at that point in time that we realized that as civil society organizations, we cannot do it alone. There has to be serious partnership. So that was why during the pandemic, we had to partner with the Medical Women Association and then with the psychosocial therapist, because of the lockdown, there was an exacerbation of violence against women and children because of the lockdown. They could not access services such as feeder services. They could not access health services, and it became worse for them. Of course, what happened in Nigeria is no news. It was all over. Some people lost their lives because of that. And so for us in FIDA Nigeria, we realized that in times like this, you cannot help but partner with one another. Because in our country, well, the Constitution provides for gender equality and non-discrimination, but women still continue to suffer injustices and marginalization, which is as a result of discriminatory laws, religious and cultural norms, gender stereotypes. So this has not helped issues when it comes to women. And talking about health, that is one fundamental area that I can say that our government needs to do more. Dr. Ibere talked about it, but in Nigeria, even though we may say there's been a bit of an improvement, because with this year's budget, there's a great improvement on it, but the main thing is for us to see that this budget is applied effectively to apply the lives of women, children, and the vulnerable, and people living with disabilities. Most times you hear a large or huge sum of money allocated for health, but you hardly see it on ground. And during the pandemic, you go to places, all they have maybe is a patent medicine store, where the person manning that patent medicine store may not even know anything about the ailment that you're, but even at that time, those patent medicine stores were not even open. And which is to say that most countries in Africa have never really considered anything like emergency, like the pandemic that came up. So they were not prepared. So it took them unawares, and the vulnerable suffered a lot for it. I can tell you that we had quite a number of interventions in our work during pandemic, the COVID-19 pandemic. Women who went into labor, they had no access to healthcare, they had no access to anywhere they can go for. So we had to come up with emergency lines, hotlines, where people could meet us. And so we had to intervene. Quite a number of our branches had to step in, go to villages to bring out some women that were in labor. And that's why I said partnership is very key. And the Medical Women Association that were in those branches were quite helpful. And then for women that were violated during those periods, it was quite a traumatic experience for most of them. Of course, some lost their lives. And so the psychosocial therapists that we partnered with came on board. So having said that, what I want to say is that I don't think it is an issue for ministers. Like us in FIDA Nigeria, we have laws that are discriminatory in nature. And of course, with the spike in sexual gender-based violence, the federal government had to come up with presidential task force, emergency task force on sexual gender-based violence. The governors forum in all the states of the federation came up to say they needed to do something about this. And I can tell you that it was courtesy of the civil society organizations. So after the end of this pandemic, the civil society organizations had to follow up to ensure that these laws that are gender neutral, these laws that are against sexual gender-based violence were adopted. And we got almost all the states. I can say that only 1 or 2 states have not adopted that law. Those laws were adopted in those states, courtesy of the work of civil society organizations at the outbreak of the pandemic, the COVID-19 pandemic. So
I think you have shown the need for partnerships and that it can help and that it, you know, it can make a difference. So if I'm hearing you correctly, ladies, I'm hearing the need for not having a one brush to paint everyone. There's a difference between men and women and how their risk factors. And I never really thought about it quite like that before. And that's why I said, Abby, this is great data for action. Asha, you talked about the need for changing the laws. We can't make change without changing the laws. And then Rhoda came in now to talk about almost the same thing in a different place. So how do we, I'm going to come back to you, Abby, in terms of, you know, truly having a gendered and a specific approach that includes everyone. How do you see us getting there? You have some good data for action from your area. What's next?
Yeah, I do think it's really important in terms of the data and understanding that living with an NCD is actually quite nuanced. Sometimes we take, like you said, a broad brush approach to tackling NCDs, but we have to realize that people living with NCDs are a variety and a diversity of people. We have the old, we have the young, we have men, we have women, we have a range of different types of NCDs as well. And so all of that needs to be taken into account. And what that means is that we have to develop intersectional policies that are really very well designed, structured, and nuanced, that take into account all of these different factors so that we can create policies and universal healthcare that's equitable. This is very challenging to do, but I think it's something that we really need to work towards, because at the end of the day, there are a lot of people that are suffering because there are huge gaps in healthcare and huge gaps in terms of policy development in order to address these. And they're very practical things that we can do. We can have the policy, but as CSOs, we can also develop programs and interventions to address a lot of these issues and also fill the gaps that exist. And so one of the things that we're doing as a result of the research that we just conducted is that we've just created or just implementing a project called Empower, to empower women that are living with NCDs, really to address some of the issues that we identified in this project.
Wonderful. That's great news. And Professor Hans, how do you see, you know, what we learned from the pandemic in your area? Are you seeing the application of what we learned in your area?
I think the laws are there in place, but there is no implementation. When it comes to implementation, who is involved? The social structures. So unless social structures don't change, the law in itself is not enough. And I think society awareness creation among society is very, very important, even much more than the laws. And the other thing that we have done and which has become important is women's solidarity networks. That helps, as does the awareness creation.
Agree. And Rhoda, would you say in Nigeria, this education exists in the community? Do you think people are aware of the need to see health as a human right? You're muted, sorry.
Okay. Yeah, there's much more that could be done. I can't tell you that there's a lot of such awareness. We need to do more of awareness creation. There has to be sensitization. And what I want to say again is talking about law, like the last speaker said, it is not just enough for us to have the law. We need to move, and government should understand that when you have a law in place, there has to be some proactive measures that should be put in place for effective implementations of these laws. And then there's need for mobilization of resources to support the full inclusion and participation of women in decision making, because most times you find decisions being taken concerning women, the youths and the children, the people living with disability, but they are not there. So there has to be a deliberate effort on the part of government to ensure that women are included in decision making when it has to do with their needs. And we have to also engage the men for, let them understand, and that has to do with sensitization and awareness creation.
Thank you so much. So I'm going to thank you ladies, Abby Bejo, Professor Hans, and Rhoda Prevel-Theodin. Thank you so much for sharing your perspectives. We're going to move now to our third section, where we actually work now on developing our key asks that we want to put before the Commonwealth Health Ministers at their meeting coming up on May 20th. Now, they meet every year in May ahead of the World Health Assembly in Geneva to discuss how to improve the resilience of health systems and advance universal health coverage in Commonwealth member states. So the meeting builds on existing commitments made at the Commonwealth Heads of Government meeting in June 2022 and the previous health minister meeting last May. So now we want to hear from you, and we have been capturing your comments on what health ministers should put on the policy agenda regarding universal health coverage, and specifically with respect to the needs of women and girls. So we have on screen already a document where we're going to be collecting your thoughts. We're going to ask you, the panelists, as well to come in, and we're going to talk about this for a bit. So let me just switch screens here so I can see what we have on screen. Okay, so far we have greater consultations with people on the ground needed to determine needs at the community level. Health systems need to be equipped with reserve capacity that must also be agile. Governments need to adopt learnings from other pandemics, including HIV, to ensure better pandemic preparedness. All right, maybe we'll look at these ones first. So let's start with these three in terms of the need for greater consultations with people on the ground to determine the needs at the community level. Is there anything else that anyone from this group would like to add to that? Oops.
Yeah, I think that, sorry if I can jump in, I think it's really important even to say it needs to be meaningful consultation that needs to take place between people that are living with NCDs or the target group. It must be meaningful consultation, and it must be regular consultation as well. And I think it also needs to be consultation that's almost designed by the people for the people. You know, they need to be a part of the whole process of leading that as well.
Just also being reminded that you can raise your hand if you'd like to make a contribution. If you're not current, there you go. And we have Dr. Harjat Kosa as well.
Yes, thank you. You know, one thing that when we're looking at what we have learned from COVID is we need to be prepared. And one thing that we are not talking about is long COVID. There has been so many anecdotal, references are coming up, so many, country level, so many indigenous women has come up, but the references need to be, better understood, studied, and we need to have focused strategies and approach when we are looking at long COVID, especially from, I'll again use the word, gender transformative lens, because women in a household is the last one to be, getting shots in the arms or getting services. And, we really need to think from this. Yeah, thank you.
Thank you so much. And remember, any of the attendees can come in here and make a contribution as well. Coming to you, Dr. Wolumbe.
Yes, maybe just to add on to this statement, because I think it's really critical for us to have that consultation mechanism. I think it's to create a sustained mechanism that exists as part of the overall structure, because then it's part of the DNA of how you re-engineer our healthcare system.
Okay, and I have to tell you guys, this is a rough document. So we're working together. We're actually in a working group now, and it will be tidied up before we send it in, but we're just getting all of your comments. So now we've added regular and sustained mechanisms. So that's good. Dr. Harjat, is that what we call a legacy hand? Or are you coming in again?
One thing, when we are talking about sustainability also, the important thing is integration. We have beautiful vertical models, and how do we integrate the existing health systems so that we are able to provide a holistic response of services. So I think we need to talk about integrating, so integrated responses, integrating services, at some point. Yeah, thank you.
Okay, great. Thank you so much. I think we're adding that at the bottom. Did you intend for that to be part of the first comment, or can we leave it as a separate bullet for now?
I think it should be separate. And
okay,
we can expand and talk about ability, equity, and when we talk about the integrated response.
Okay, thank you. Donna, I see your hand up. Which comment would you like to?
I want to tag on to Kojat's comment and say that we have to invest more invest better. I think that is going to be very crucial because our government's current investment commitments and public spending for health are inadequate for us to achieve universal health coverage.
Thank you. Noted. Thank you very much. Professor Asha?
Yeah, I just wanted to talk about the HIV inclusion in pandemics. I think there are a number of pandemics which have been much more, have effect. So if you put HIV, it restricts it. So if you leave it pandemics in general, it might be better. And the second one was, can you go back
to the top?
Yeah. Yeah, about awareness, I think it's a little weak. We need to strengthen that part. That there was one.
You probably need to scroll down a bit. I didn't see awareness yet. Oh, here it is. In terms of health planning, women need to be included. Yes.
Yeah, it looks very generic. It should be stronger, involved through sensitization and awareness, among communities and among governments and communities, but sensitization and awareness.
Okay, thank you. We've added that. Dr. Ibire?
Yes, I also wanted to comment to strengthen that particular comment about consultation and inclusion.
First one.
Women have been consulted to death. We are always the first people to respond to surveys. We contribute, and then somewhere along the line, the decision-making process, our views get left behind because we are not in the decision-making spaces. Now, everybody is very familiar with the statistics about, in the health sector, for example, at least 70% of the workforce are women. The higher up the chain you go, the rarer women become. And so long as we wait for it to happen organically, it's going to be another, my grandchild's lifetime before we will have the sort of representation at leadership and decision and policy shaping fora that ensures that the views of these women we consult feed into the policy and the systems that we develop. So my proposal is that we actually need to be intentional about representation of women in decision-making spaces. That means taking positive action. As we've seen it in the general government system, is those countries that have set quotas, that have mandated expectations for representation, that are doing much better in general government representation of women. And we need to take the same approach to critical health policy decision frameworks. We must specify the requirement for women to be part of the decision-making process, not just consulting them and getting the information and then ignoring it.
Thank you. Thank you for saying that. I concur. I totally agree. Now, before I come to you, Abby, we do have a participant who would like to make a comment. Marianne Siapara. She's president of the Commonwealth Pharmacists Association. Marianne, would you like to come in now and give your comment? I believe we will unmute you. Marianne, are you able to speak? Yes. Okay, I'm not hearing Marianne. So while we work on that, I'm gonna let you go to Abby. Abby?
Okay, now.
Hold on.
Can you hear me?
Yes.
Okay, I'm Marianne Chapara, president of the Commonwealth Pharmacists Association.
Welcome. Thank you.
We have seen a lot of health inequities following the pandemic, especially among women, children, and the most vulnerable. These inequities include access to health services, as already mentioned by my colleagues. Also, there has been interruptions of the vaccination programs when it comes to children. We have seen, as already mentioned, an increase in mental health illnesses, especially amongst women. sexually transmitted diseases, which remained untreated because of the pandemic, and also people failed to access health services or couldn't access health services. And as such, their condition, non-communicable condition, deteriorated further. Furthermore, as stated before, long COVID has had a negative the health of term to non-communicable diseases. We have seen people developing diabetes, people having problems regarding their pulmonary function with asthma and also heart problems. And all
Marianne?
these are having a negative impact on their healthcare.
Agreed. Thank
Apart
you,
from
Marianne.
that,
Yeah, Marianne, at this point, we're working on the formulating the key asks. So is there a particular ask that you would like put into the document at this time related to what you were highlighting?
as regards to the health inequities, you know,
Yes.
women, vulnerable people, and children are being affected negatively when it comes to the present situation, mental health, access to vaccinations, delay in vaccinations, non-communicable diseases.
Okay, so you would like us to highlight those as priority areas, correct?
Yes, and
Okay.
apart from that, both COVID, both the pandemic, and
And
also
long-COVID.
the war in Ukraine has created a greater shortage of medicines worldwide, and that I would like to develop later on, please.
Okay, thank you so much, Marianne. Thank you so much.
Thank you.
So we will make sure we include those as priorities as well. Abby, just hold. I'm going to go to Donna Juliet, another member of the audience. We really want to get these comments in as well. But I see I have 3 panelists who want to come back in. Donna Juliet, are you able to speak?
Yes, thank you very much for giving me opportunity. I'm calling in from Uganda. I know my country in my context has very good strategies, but these are not being implemented. My ask will be that there's need to intentionally invest in strengthening community-based healthcare, because we have volunteers that work at community level. These are never recognized and facilitated. And so if there's investment in strengthening community-based healthcare, some of these challenges can be adequately addressed at community level before they get really serious. And then I would also like to say that women participation from community level must be strengthened and prioritized, because we women are the ones who get most affected, whether mental health, physical health. We face a lot of economic challenges. And so if our health is not prioritized by involving us in decision-making from community level, participating in providing community healthcare, we are still going to have this vicious cycle. So this has to be intentional. Thank you. Over to you.
Thank you so much, Donna. That is a really good point. Thank you very much. I think we've captured that. Okay, Abby, I hope you remembered your point. I'm going to come to you, Abby, and then Donna, and then Rispa.
All right, thank you so much. I think I just about remember my point. So I wanted to come back to the consultation, and it kind of adds on to what another speaker was saying about the fact that we do know what a lot of the issues are. So we have to be very careful that the consultations that are carried out with people are consultations that provide new information for us to act on, so that they address gaps, so that we're not just really duplicating a lot of the information and the knowledge that we already have. So we just have to make sure that the consultations are strategic and that they're designed to gather new information. The other point that I wanted to make was around the nature of the implementation of policies and also universal healthcare. One of the things that came up in the work that we did was just the huge lack of empathy when it comes to certain health conditions. And so we just need to build into policy and policy implementation and UHC implementation empathy, from across the board, from everybody working in healthcare. because there's certain conditions that can be trivialized and there's a lack of empathy. And so we just need somehow to build in that empathy. And then I also think it's important, there are particular women's health issues that could get completely ignored. And I think it's important that somehow we could ensure that these conditions get more attention. And I'm thinking of the issues around, you know, things like fibroids, endometriosis, which I mentioned in my presentation earlier, polycystic ovary syndrome, and even just general menstrual health issues, which tend to be ignored. And all of those, I think, need to be considered when we're looking at gender universal health care and health in general. And somebody's also in the chat has said endometriosis. So that's fibroids, endometriosis, PCOS, adenomyosis, all of those issues tend to get ignored. And so we really do need to focus on them because there are many women suffering in silence. So back over to you.
Thank you so much. I think we've reflected that. I think it's really sad that we have to write down that we need to be empathetic, but it is what it is. You know, that's really sad. Let's come to Donna.
Yeah, I'm not so sure that we captured this earlier, but I'd like to see that we review and reform the national policies to make them more relevant to the health of women, children, and adolescents, with a focus on addressing health inequities, including sexual and reproductive health affecting these particular groups.
Thank you, very important. I'm going to come to you, Dr. Walumbe, and then I have another member of the audience who wants to make a comment, Claudette James. So Dr. Walumbe first.
Thank you so much. So I think for me, we've talked about investing more, and in the context of this document that we're trying to work on, it's about where should that investment go. And I think the key thing I would like to see in this document, maybe it's in the earlier portion, but is around primary healthcare explicitly being talked about and outlined. And I'll say the reason for this is because how do you make sure that the funding that we're talking about raising is effectively reaching the service centers? And primary healthcare, I mean, there are many reasons why you should invest in primary healthcare. But just to talk about the NCDs that we've just been discussing, just to talk about, that's where quality begins in a health system. And also that's where better health outcomes are actually retrieved from. So I think it's really important, and really just to, tag on to one of the comments from the chat is from Kenneth Macharia around, looking at health financing with a gendered lens. I think that's really important, because when you have the focus of, okay, we're talking about financing for primary healthcare, for instance, in the context of UHC, then you start to look at what kind of services should be funded or provided at the primary healthcare level. So that's what it would be really important in terms of giving the Commonwealth Ministers direction. It's to look at primary healthcare financing with a gendered lens, because that's actually where the investments really go further in accelerating, gender equity. Thank you.
Thank you so much, Rispa. Let's go to Claudette James in our audience. I see you, Professor Asha. I'm gonna come to you.
Thank you so much. I'm calling from Jamaica. And
welcome.
On the point of empathy, the whole business of purposeful policy developed for training of healthcare providers, healthcare workers, to increase their sensitivity to our patients. The rape victim who comes into the emergency room shouldn't be sitting around waiting to be seen. There should be a system in place to deal, to really address that person's problem. In the antenatal clinic, or a teenage pregnant girl who comes in, that she's not abused verbally by the healthcare providers, that they are very sensitive to these persons who come in for their care, and equipping them to identify and appropriately refer them for care, the abused woman who comes in, so that they are equipped. So purposeful training of these healthcare personnel should help. It will help to support our women and girls. And the whole business of having policies in place for psychological. Quite often we look at the physical issues, but the psychological care of these persons who come to our health services. And I do support the whole business of increasing investment in health. The budget should be larger in the health services. Thank you.
Thank you so much, Ms. James. Really, really good. Excellent points. Thank you very much. Professor Hans, I hope you remember your point. I have you holding for a little bit.
I wanted to say that every woman should have the right to live in a community with the support that she requires, not forced upon her. And secondly, we have still 70% of the population in most of our countries are rural women. And I think consultation with rural women are very, very important if you want a holistic, broad-based decision making. And third is, I think we need an assessment of implementation. We say implementation, but we don't assess the implementation that is there. And for that, I think budget should be there to see that not only for implementation, but also I think for mental health, there should be a specific budgets.
Okay, thank you very much. I'm going to go back to the audience before I come to you, Dr. Kosa. Kalkidan from Women in Global Health. Would you like to make a comment at this point?
Thank you so much. Can you hear me?
Yes, I can.
Okay. Something that I want to highlight is regarding the ensuring fair and equal compensation and opportunity in the health workforce. As you know that 70% of health workers are women and 90% are nurses and midwives. So they are the one delivering universal health coverage. So we need to ensure there is a budget for healthcare workers to ensure there is a fair and equal compensation and opportunities. So without women health workers, there will not be any universal health coverage. That is the first point that I want to raise. The second point is we need to collect and analyze data that is disaggregated by sex and gender. So in order to break down barriers that prevent girls and women from accessing health promotion, prevention, diagnosis, and treatment, every data, including, for example, COVID vaccination rate or any illnesses or anything that we collect, the data should be disaggregated by sex and gender. So those are the 2 points that I want to make. Thank you.
Thank you very much. Okay, so maybe we should scroll back up. I'm going to come to you, Dr. Kosa. Let's scroll back up and get a look at what we have as Dr. Harjot makes her point. And maybe we can also then look through after this to see if there's anything in here we want to build on. So over to you, Dr. Harjot.
No, thank you so much. I had also noted down Kalkidan's point on, this, having data, which is very gender specific. There are some points, which some participants has shared, where strengthening the primary healthcare setups in countries who were like, everybody was affected with COVID, but, respond was delayed, especially when you come to South Asian countries like Bangladesh, they received vaccination quite late, So we have to do that kind of analysis also. And also, when we are talking that, women should be engaged, we have to open the definition. It is women, communities, we also have to talk about trans women. We also have to talk about the larger gamut of communities. So we have to expand on our definition of gender when we're looking at. And lastly, there should be somewhere written that how CSOs and communities are engaged at each point of this discussion in future course also. We need, our future discussions to be based on the principles of human rights, and we need CSOs and communities, at all levels to discuss, to talk about it. Thank you. Like just we are doing right now. Thank you.
Exactly. Now, I can't read that. I don't know if you guys can. We're going to allow one more comment from our audience. But we're going to maybe do a quick scan of this to see if there's anything that anyone has a burning desire to edit or make a change to. So let's go to Pomolt Mutemwa. I'm not sure if I pronounced your name correctly. Please forgive me if I didn't. Oh, we still have some more time. Okay, we do have about 6 minutes left. So let's go to Pomolt, and then we'll do a scan of the document and make some more edits.
Well, thank you so much. I wanted to mention that we should invest highly in research with gender lens that is able to shape policies that reflect statistics and evidence in order to meet the needs of women in various communities.
Thank you so much. I did say your name wrong. I apologize. Mulo. Thank you very much for that. And once Jillian is finished typing, we're going to do a scan. I'm going to ask all of you to take a look at the document and see if there's anything that we think is, that anything is missing. That's okay. Apologies for messing up your name, Pumulo. Okay, so we have a resilient health system accessible to everyone. Primary step to pandemic preparedness, monthly universal health coverage. Sexual and reproductive health and rights, more focus needed on this area so that women feel comfortable, and universal access to SRHR care. Governments need to use a gender transformative lens when developing policies and services. Attention to the bottom 20%. Who are these people? We didn't really discuss this, but we know what we mean here. We need to know who they are to be able to provide the services they need. I think we did touch on this when we talked about the most vulnerable. Who are they? And how do we help them if we don't know who they are and how many they are and where they are? Please jump in at any time, panelists, if there's something you wanted to add to any of these. Global solidarity is needed to effectively respond to future pandemics. I mean, that's a given. Strategies needed to be more focused on national and regional levels, especially focusing on women who are marginalized in fragile settings such as Sri Lanka and Afghanistan. And I think someone also mentioned the war in that's currently going on as well. So maybe we need to say areas where, you know, there's violence and war, or maybe that wasn't what we meant by this. Yeah. Sustaining investment in health. Insurance mechanisms are not the only way to fund health systems. Do we want to expand on this at all? Is there anyone here who wanted to say anything about this one? I know Dr. Ibidere mentioned this earlier. Do we want to add anything here, or is this fine?
Yeah, if I could jump in there.
Please, yes.
Yeah, so we need to explore how government's responsibilities in provision of health services. Currently, the approach taken to insurance-based systems is, first of all, it is predominantly therapeutic services. It's secondary healthcare. It's health treatments as opposed to preventive healthcare. It tends to focus on the higher end, specialist services and doesn't actually encompass primary healthcare services. So by doing that, we're actually skewing the health system and to the more expensive end and to the making it even less accessible. So if we are in talking about universal health coverage, we need to start by first and foremost defining the primary healthcare system or the community health system. I actually prefer to use community health system because we shouldn't forget that a significant proportion of our health support can be offered outside the healthcare. We immunize children in schools. We do nutritional assessments in schools. We do health education in schools. So I prefer to look at it as community health services delivered in the most appropriate place as defined by that community. Now, if we invest in that actually increases the chance of moving people upstream towards healthier living and reducing the burden on the more expensive end of the health service delivery. It also allows us to move away from what we have at the moment, where we're very reactive to infectious diseases and the consequences of non-communicable diseases, to start thinking more upstream about prevention interventions closer to the individuals. If the only way a diabetic is ever going to get treated is by having to travel however far away their local hospital is to see a specialist, the diabetic care is going to struggle. But if we embed prevention of diabetes and the management of early cases nearer the individuals, we're less likely to need the very expensive problems and the managing the complications of diabetes. So we need to stop looking at universal health coverage just by where the money goes and focus on where the service is delivered. I think that's the difference that I would propose.
Okay, so you focused in on one key ask. I'm going to ask maybe two others to give me what would be one main key ask you'd like to put before Commonwealth Health Ministers in May. Rispa, you have your hand up, so I'm going to kind of put you on the spot. What would be your one key ask that you would like to get on that table?
I think my key ask was actually around what Dr. Berry was saying. And it's really that the reforms that, especially the health financing reforms that countries are going through, I think countries, especially, I would even flag to the African region, that these are context-specific reforms. Not all approaches need to be, like, they're not all applicable in the same context. And I think it's really important for us, especially in the context of sustaining that investment, let it be sustained. And even if it means starting small, that's where all these countries that, you know, people tend to aspire to, that's where they started, in those smaller investments, and making sure that those investments are context specific. So I would just say a focus on primary healthcare, and or as Dr. Ibera says, community health systems, more specifically. But yeah, that's what I would say. Thank you.
Thank you. Right, I'm going to ask you ladies to go quickly on this one because we need to wrap. Abby, what would be your key ask?
I think my key ask would be that the approach is really intersectional. So yes, we're looking at gender, and gender is the core focus, but we need to understand that we need to look at gender, age, income, type of disease. So it just needs to be really intersectional so that we don't miss anything. So I think that would be my take-home message, and also that we infuse empathy into everything as well. So I think that would be my take-home.
Thank you so much. And finally, Professor Hans, you got the last word. What would be your key ask?
Thank you. I wanted to say that access to affordable health, everyone cannot afford. So it has to be, health has to be affordable. And I think when you're writing sex desegregated, maybe put age there.
Okay, great. Thank you so much. Thank you very much for everyone who gave their comments in the chat and Q&A, who came in and gave vocal additions to this as well. We're going to be working on this as we continue to lead up towards that meeting in May. The Commonwealth Foundation's next critical conversation is all about celebrating and challenging the Commonwealth Charter. Next month is the 10th anniversary of the signing of the Commonwealth Charter, and the next critical conversation will be held on March 14th. It will feature young leaders from across the Commonwealth. So we want you to join the conversation as they share and discuss their views and aspirations for the Charter. You can also find a link to register in the Zoom chat coming up. I want to thank all of my guests today. Thank you so much to everyone who presented, asked questions, to everyone who participated in this discussion. I thoroughly enjoyed this conversation. Also, if you have not signed up already, you should join the Foundation's digital discussion platform. I've done so, the People's Forum. It's an innovative online discussion space for activists, practitioners, artists, civil society leaders to network, share ideas, and build solidarity around some of these issues we've been talking about today. So please use the link posted in the Zoom chat. There'll be a QR code coming up as well soon, so we can join, meet, and continue to strategize with other fellow health activists. We would also love you to continue the conversation on social media. On Twitter and Instagram, you can use @CommonwealthOrg. And for those joining the networking session, please go to the Zoom meeting link, which will be shared now. Thanks so much for joining us today. I really enjoyed this conversation. Thank you and goodbye.